All right, now we can get down to business. This is Kevin McGinnis welcoming you all to the July 2019 Community Paramedicine Insights Forum, sponsored by the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research in EMS. My usual partner in crime, Gary Wingrove of Mayo, normally runs the system in the background here. Unfortunately, he fell ill this morning. Nothing fatal, but not good, and certainly not on his feet. So we wish him a speedy recovery. This month, we are pleased to have Dr. Peter Tange and Dave Johnson from North Memorial Health Systems in Minnesota. Pete has been in EMS for well over 25 years. He is an emergency medicine physician who practices clinically with North Memorial and is also the medical director for the North Memorial Community Paramedic Program. They're going to share with us today their efforts at what certainly has become a leading light in community paramedic programs in the country, with Minnesota having led on such things as reimbursement for community paramedic services statewide, thanks to Dr. Mike Wilcox and others. North Memorial has had a very active community paramedic program, having managed to work reimbursement with it through their ACO, Medicaid ACO program, and have had a number of other successes. Pete has been working with the program to incorporate some telehealth components and is going to bring us up to speed from the last time that North Memorial was featured on CPIF. And I'm going to simply turn it over to Pete and have him introduce Dave. Pete?
Yeah, thanks, Kevin. Excited to share some time and our recent experiences incorporating telehealth. I'm lucky I have one of my partners, David Johnson. We're in the same room presenting because one of the things we've learned is that sometimes the audio and being apart causes challenges, so we're together. David's long time and one of the pioneer community paramedics, and as well as starting to get to be a longer and longer time as a traditional 911 paramedic too, in critical care. David has many roles in our team. In addition to being a caregiver, he's also our technology guru and resident geek, and helps and has been really instrumental in getting a lot of the technology and up and running, and then troubleshooting it as we go along. So it's been nice not to just have a call line to call into and complain to, but actually to have someone who's working with our team and knows what we're doing. So we're going to spend our goal really is to have a conversation, but have it structured around some of what we've learned in that. So if people have questions, just let us know, and we'll make time for sure at the end to go through things in whatever details required. We're excited to follow up on Houston's presentation about the Ethan network back in April, and have tried to structure ours to be somewhat complementary to their presentation too. So we'll begin. And what we want to talk about is how, not just telehealth, but really how, from our perspective, the community paramedic and physician relationships really enhanced through the telemedicine, and in turn then that helps the patients. David and I work at North. One of the things that we do at North is we're focused on a good experience for people, and part of that has been changing from calling the people that we care for, instead of referring to them just as patients, we also refer to them as customers, so you'll hear us using that kind of interchangeably. And This is outside Minnesota, but back in April when there was snowbanks up over our heads. Today it's pretty sweltering hot. I don't have any disclosures. I'll let David give his.
And then my only disclosure is I'm teaching a community paramedic exam prep course at Relias and Distance CME. So that's all I've got to disclose.
And so our objectives today is to briefly review telehealth and telemedicine. It is exciting. Even though these things have been around for a long time, I think they're finally starting to gain some traction. So to just do a very basic primer on that. And more importantly, just to level set our vocabulary. And then show how we've been able to enhance our relationship between me as the doc and the community paramedic team, but also to how we've been able to start making our practice more sustainable when it comes to Medicare, and how we've used transitional care management to do that, and then and just share about our program. So our concept or our kind of vision of community paramedicine is that there's all these healthcare resources on one side. We are all under an umbrella of a lot of community resources. And in Minnesota, I think we're very fortunate to have a lot of community resources. The big challenge is that they're not always well integrated, or I think that's where we find a lot of opportunity to live and work, is in trying to integrate the person's needs with the community resources and with the healthcare resources. I see my role, and I think the role of an EMS doc is as part of that, and really closely connected to the community paramedic. Telehealth is something that's really allowed us to take that to another level that I'm finding extremely rewarding. And we also want to call out that we look for our community health workers and other community health providers and really try to connect with them as well. And then at the bottom, we still recognize there's this group of people in the margins that we try to keep our eyes on, even when we don't really know exactly how best to serve them. But this is the model that we work under. And when we think about telehealth or telemedicine, I think we use these terms interchangeably, or commonly we interchange those, but what we are really referencing is that telehealth is a large topic or subject. Within that includes the fruit of telemedicine. RPM stands for remote patient monitoring. Again, I think a very exciting component of telehealth. And then there's the non-clinical telehealth. So in some ways, even using this webinar as a form of telehealth where we can have a meeting or share information that maybe is not directly related to a specific person or patient or customer, but has other operational or medical benefits. So there's probably other fruit there, but these are the three areas that I think about. I don't know, David, would you throw anything else on your fruit tree of telehealth?
Not in our current utilization here at this organization. I think the opportunities abound, especially as we look for kind of a more meaningful interaction between all the different pieces of technology we have. But I think the biggest thing is making sure that they live really neatly underneath this this telehealth tree, and we break down the barriers. So
yeah, and so we're not going to talk about like artificial intelligence or any of those other pieces that kind of fit into here in a really exciting way. But our overall goal is to make sure that we're expanding access or making access accessible to our customers, to make managing their health more or easier, and then to improve some efficiencies. So for us, telemedicine is real time. What we're going to share with you is all based on live video. We use the iPhone. We'll talk about how we use that as well. and then maintaining a HIPAA-compliant platform. So we are not currently using any asynchronous telemedicine or store and forward, although I think that's super exciting when I think about things as a doc, where a medic could be out and or for our team where maybe myself and the community paramedic, we're seeing someone's foot wound, and we want to take those pictures and store them in our medical record and then forward it to a podiatrist to review the next day. Or if we're working on a Saturday and they're off, they can look at it Monday and act on it and still feel like they're getting reimbursed for their work. I think that asynchronous store and forward is really, really an exciting option, but we're not doing that yet. We're not going to talk much more about it. And then the remote patient monitoring. Our budget is, we strive for break even, and we get there. But as a result, we don't have a lot of extra dollars to reinvest in monitoring equipment for patients, so we try to connect with those things that are in existence. But again, in Minnesota, it's not uncommon for us to be caring for a patient whose cardiologist is in a different system, but then their health insurance provider gives them the cool scale that's monitored by a nurse somewhere else, and the connections are very low-tech in terms of, or the integration is very low-tech. The connections to the nurses is great, but it's we really have to pull that information out versus getting it sent to us. So right now, our program's not relying on remote patient monitoring. There's another opportunity, I think, to develop that as community paramedic programs mature.
I think the other bullet point I would add into this too is looking at ways that we can leverage patient portals, however they may exist within the systems. I mean, it's a little bit covered in there, but I think allowing the patient to connect directly with us through, like in our system, we happen to use Epic as our electronic health record, so our patients have access through MyChart. And there's a lot of really cool opportunity coming up as the technology continues to advance and the organizations begin to utilize it more meaningfully to create these ways that patients can either access our program or the primary care providers. Right now, it's really focused at the primary care providers, but even making us just as important of a nexus in their healthcare team.
And there's just recently been some development in Minnesota, just with our last legislative session, where the community paramedic's been recognized by the state as a telemedicine provider, which then I think opens up the door more for what David was mentioning, where now the community paramedic can do some of their subsequent and follow-up work via telemedicine. Connecting with the patients and when the patients are at their home. And then the medic now can be in our truck or in our office or across the state helping care for the people that they know about. So that's sort of the kind of our primer on telemedicine. The reason I mentioned the distance is this is a map of our service areas. It reflects our helicopters, which cover almost the whole state. We're the little sunshine in the middle. That's our community paramedic program. And so when we talk about our opportunities to continue to grow and support improved health across a wide area, what we're looking at is ways that we can connect more with our ambulance and traditional 911 services that are out and scattered around the state of both Minnesota and Wisconsin. So I was doing a lot of driving up to Brainerd for a pilot project, which was really, I had a good time doing that, but in terms of efficiency was pretty challenging. So the telehealth piece really is exciting in this regard as well.
Yeah, when we first got into the world of transitional care management, Dr. Tangy was actually traveling out to many of our customers' homes already to do the intakes, and from a mileage on his pickup truck standpoint, telemedicine has been a godsend for Dr. Tangy, but also has been a godsend for the community paramedic clinicians in and of themselves, because we're able to really spread Dr. Tangy on, really meaningfully kind of across the entire spectrum and across all three of the different, we run with, on a weekday, we have 3 community paramedics working in the clinical setting, so being able to, have Dr. Tangy kind of go bam, 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 we can really multiply the force we can work with very effectively and efficiently.
And so just a little bit more on North, we're kind of, where we are a small system, our main clinic base is in the northwest part of the metro in Minneapolis-St. Paul. We have 2 hospitals. One's a level 1 trauma center, the other one's a community hospital. We have about 750 employees within that 6,000 who are EMS specific. And then we have the 19 ambulance bases. This is our team. It's evolved a little bit. A couple people have retired or moved on, and then we have 3 new people we'll have to add in. But
I'll have to get good at Photoshop here. I suppose as the resident tech advisor in the department, I'll have to figure out Photoshop soon.
But we kept this picture in our current presentations because it also highlights, as we're talking, we're also representing our neighbors and community partners. So this is a cool group that does emergency food rations. It's called Matterbox. We use them, so if we encounter someone with food insecurity, we have this box of shelf-stable food that'll help bridge them for about 24 hours till we can get them connected with a food market or other resources. So.
And that's transformed also into all of the 911 ambulances and our non-emergency divisions also having these matter boxes in their ambulances, so the ambulance clinicians are enabled to provide a little bit of food bridging as well as a resource connection to a food resource.
Yeah, so that's been fun to see how the community paramedics influence and connections have been able to spread back to our 911 providers. And then as we narrow in on our metro area, these dots reflect addresses that that our community paramedic program has been tasked with or given the opportunity to serve. And the green and blue is the highest density, yellow reflects more than one call, but these little red dots reflect individual addresses that we've taken care of over the last few years. And what it highlights is this is a good, without traffic and road construction and snowstorms, this is a good 2.5 hour drive between like Arlington down here and up by these lakes up by Taylor's Falls. So obviously we try to run our operations so that the same person isn't going back and forth, but on a Saturday when there's just one person, the potential for a lot of mileage is pretty high. And we'll talk a little bit about one of the efficiencies we've measured, but when I was before we instituted telemedicine, I was still spending a lot of time driving around, which was good for podcasts, but not great for efficiency.
And the gray area you see highlighted is what our ambulance service area is for our metro ALS service area. So we kind of have generally the top half of Hennepin County very broadly.
Yeah, and our 2 hospitals are in this area here and up in here. So that's one of the challenges that we deal with. What I love about, and I think anyone listening, I'm sure what we all love about our work is that it's so hands-on. So this is one of our partners, Dale, and got fixed. Doing some wound care and foot care, and I think anyone who's doing community paramedicine knows that podiatry quickly becomes one of the specialists of it's good to get to know your podiatrist, because there sure is a lot of foot stuff out there. And to me, I think this highlights, like, how are you going to take care of this? If I was a podiatrist, how would I take care of someone's feet via telehealth? I think it's pretty challenging trying to figure out how to accomplish that mission. So insert community paramedic, who now can not only take care of the person's foot, but can also put that into the context of helping them manage their diabetes or managing their lymphedema or chronic heart failure. So this is where I think that the whole concept of telemedicine and community paramedic really opens the door for some exciting work, because the skill set that the community paramedic brings in terms of a compassionate problem solver and good clinician, combined with the technology to connect to the right specialist, it's really cool. I just like watching Dale work here too. And what I'm pausing to think about too is we have, not to just be smoke and mirrors and say everything's worked great. We've had our share of people who've still gone on for amputations and that, but the ability that we've had to augment someone's home care and help prevent amputation, we've had a couple good successes with that. And that was even before telemedicine. That was just the hard work of the paramedics. And I would pause also here just to, our work is really based on collaborating with those other resources and especially home care providers. So we've had a couple people where the home nurse comes out twice a week to do the wound care, and we're going out 2 other times a week to augment what is covered. And that's made a big difference. And I think the home care nurses and staff, they're slowly figuring out what to do with us, especially when the medics are talking to me on the via telemedicine. And then just to remind, again, just as a reminder that this is not, although this is a new technology in some ways, really this concept of the physician and the paramedic collaborating obviously goes back a long time in our profession. So I just want an orange suitcase someday that I can put my laptop in. And so I think one question would be, well, what does an EMS doc do in this in the context of these home visits? And this was us before telemedicine. This is myself and one of our other team members, John Riley, out at a woman's house who's got chronic CHF. We're figuring out how to get her scale in the right place so that she can use it safely and that it's close to a phone line, so her bathroom didn't have a phone in it to connect to her monitoring nurses and that. So just troubleshooting the technology with this customer. Again, something I totally appreciate, be it the opportunity to go to someone's house and see them in their home environment. So that was that's what our work, it still is on it when it's needed to be that way. And when I first started at North 3 years ago, that was more of what I was doing. And so I joined North around 2015. In Minnesota, the state sponsorship of community paramedicine translated to Medicaid, the state product, being what pays for community paramedic services. And when we first started our program, we had a heavy emphasis on Medicaid. But as the clinics started to figure out what we could do and what we were doing, the need really is in Medicare. And this slide just shows how our payer mix was transforming. So in 2015, it was more blue lines, but 2016 turned very yellow. What this led to, and missed the cool animation of the skull and crossbones coming in, but what we had as our program is we had our costs were pretty steady, and then they added, and at the same time our savings were really high. So our system got super excited about community paramedics because we were saving them all this money. They took those savings, which were a lot of inefficiencies and kind of really, truly low-hanging fruit, but we took those savings and they reinvested it in the program, which included hiring a doctor, which I'm fairly high cost. We added some other infrastructure and some other people. So our costs started to go up. That low-hanging fruit started to disappear. On the bottom line, you can see our revenue, which was pretty darn close to zero until about 2015-16, when we started getting more grants and started firming up our billing process, so we were getting actually paid by Medicaid, not just sending bills somewhere, but following through and making sure the money was coming back to us. But what happened then is our costs started to exceed what we were being attributed to in savings. We had a change in leadership also that brought in a different accounting perspective, so that our savings really dropped off tremendously, the way it was being attributed to us. And so this was about the time that someone called me into their office and said, "We got to get rid of you. You're costing way too much." The good thing is they were overruled by the people above them, and then we were given a task of how do you make some money. And to go back to this was the problem, actually, not adding cost. It was the fact that our needs, what our community needed was care of the elderly and chronically ill who were on Medicare. And so we came up with a proposal to do transitional care management, and we also proposed to do chronic care management, but we did not do that. We just focused on this transitional care management, which then allowed us to start generating more revenue. And then as we've instituted telehealth, that's allowed us to even leverage that more, so that we're actually doing, we're on track to do pretty well from a revenue standpoint this year, and then get back to where the way we're in our budgets to break even. As an aside too, last year, with a couple grants that we were able to secure, we actually were one of the only divisions that technically made money, so that was a positive too. But telehealth's been really critical for this, and I'll talk about that next. For those of you, so TCM is Transitional Care Management. It's a Medicare CPT code. There's two codes. There's 99495 and 99496. These reflect the care bundles for someone who is being discharged from the hospital, and it reimburses people for helping that discharged person stay out of the hospital. So the reward is just in getting paid to do the work. If the person gets readmitted to the hospital, then they don't pay you for these codes. 99495 is someone who's deemed moderate complexity, and the expectation is that the provider, either a doctor, nurse practitioner, or PA, sees the person within 14 days with a face-to-face visit. The high complexity patients, the expectation is that they're seen within 7 days. So we adopted these codes as a way to start meeting our Medicare needs in a sustainable manner, because I as a physician can build these codes. There's a lot of complexity to TCM aside from just the patient or customer situations, but it's really intended to pay for people filling in these gaps that lead someone to come back to the hospital in something that could have been a preventable readmission. And it's a perfectly designed program for someone. It would have been harder to design it any better if the person who created these TCM services knew about community paramedics, because the community paramedic can be the one who has that initial contact within 48 hours. And then this is exactly the type of work that the community paramedics are so skilled at doing, of sizing up the situation, identifying the problems and the needs, and then coming up with a solution for that, doing their med recs and everything else. So really the paramedic does all the work, and then by including me and allowing me to be a partner and work on that problem solving, we can then submit a bill to Medicare and have that community paramedic work and my work be compensated. So it's super helpful, really. I'm just super happy that CMS has this in existence. So briefly, traditional TCM, and TCM was originally designed, again, not with community paramedics in mind, but for a hospital admission to occur, the person to be discharged, and then for the clinics to get their stuff together so that they were making sure people could get into the clinic and get the things that they needed in a timely manner over that 7 and 14-day period, and then for 30 days, so that people don't need to go back to the hospital because their medication didn't get filled correctly, or they didn't understand why they needed to keep using their CPAP when they got home because they thought it was just a hospital thing, or pick an issue, and we've encountered it in some way. And so again, for a really a highly functioning system and person, traditional TCM works pretty slick. The docs, the clinics can get paid for it, but we are seeing there was a lot of people who are getting readmitted, and there was no one in our area who was using TCM services when we were implementing our program.
And I think the other thing that traditional TCM misses is it misses the mobile component, which is where we as community paramedics are really able to succeed. And I think that's why we've seen the success, especially within trying to target these people who are the high risk for readmission, those 99, 496s, and really focusing on that group. And even though they're high complexity, for those of us who have an experienced paramedic background, they really aren't necessarily always the most complex people in the world either. Some of them may seem may level as complex, but they actually are pretty straightforward. But yeah, the mobile component, I think, is where traditional TCM just doesn't capture these people, because they come home from hospital, they still feel like garbage, and they have very little interest in actually going to the clinic to have that face-to-face encounter, especially for people who have either A, limited health literacy, or else B, the social barriers to actually getting into the clinic. Let's bring the clinic to them. let's bring healthcare to the customer where they happen to be.
Yeah, and that's, I think, one of the exciting kind of future states that we are getting a good peek at through our work, is this whole notion of more care being provided outside of traditional brick and mortar buildings. And the nice thing too, that CMS defines complex, like what we would define as complex based on our experience, CMS would define an easy day for us as complex based on their definitions. And so it is it's a really nice program to explore for people as they're developing programs, community paramedic programs. One other comment I would make is that, maybe I won't make it, I forgot my point. Yeah, I'll come back. So our program is that in the hospital, the community paramedic is part of the discharge team. We go up and round on people that are eligible for discharge in the next day or two. They get consent, and the person gets educated about who we are, what we do, and then if they agree to it, they get referred to us, and then we schedule with them once they leave the hospital a follow-up appointment. Our idea is to get in within 7 days for all of our customers. I remember what point I wanted to make is that I would say 90% of our patients meet the definition for complex care, so the 99496. But there's a fair number of people that, for a variety of reasons, we're not able to connect with in that first, or I'm not able to connect with in that first 7 days, and so therefore, by definition, it's a moderate complexity visit.
Yeah, because right now the only physician we're using for community paramedic-based transitional care management is Dr. Tangy. We're not working with our other EMS physicians yet. We're not working with our clinic-based physicians yet. Huge emphasis on yet, because we really want to see this continue to grow, because we see huge opportunities for this, not only, having, Pete be the only physician facilitator of this, but maybe, having a more meaningful connection with already we have a very meaningful connection with our clinics, but, being able to partner with, some of these other providers who are willing to articulate with us as community paramedics for their customers who are discharging from hospital.
And so that we're limited by my schedule and our ability to capture the complex versus moderate. And just as a general ballpark, so CMS, Medicare reimburses TCM services. There's a fair number of other payers that also follow Medicare's lead and reimburse for TCM services. We've found that the reimbursement for a complex episode, at the high end is around $780, low end around $480, and then for moderate is about $550 high end and like $250 low end. So that's been a very nice way to offset our costs with those reimbursement dollars. Just as a point of reference, but this is the filter that we use for our TCM referrals. And what it's allowed us to do is to stay very much focused on what does the person need. So if they're going anywhere other than home or assisted living, like we're not going out to see people in their nursing homes or other skilled nursing facilities. If they're not homebound or they're, if they're eligible for home health care, then we excuse ourselves unless they have needs that aren't being met by home care. And what we've found is there's been a couple of instances where someone's like, I don't want no home care. And then we get to their house and we're like, you really need home care. Let's talk some more about that. And the fact that they got home and have kind of learned that through experience, then they're much more willing to accept that intervention. And then as the face-to-face provider, I'm able to order home care for them. And that's been really fun. And it's been a very nice and concrete way for us to say to anyone who's concerned about home care losing market share or competing with a community paramedic, that no, that's, in fact, if anything, we help each other do our jobs better. So that's been good. And then we ask if they have primary Medicare or Medicaid, since we can get reimbursed as just straight community paramedic time for Medicaid. And then we try to filter by our clinic and or people that don't have a primary care. The primary reason for that is really practical, because so much of the work is integrating things, and when they're not in there, it's just a pain in our butt if the person's primary care is not on an electronic medical record that we have access to. So,
or if we don't have access to it, that we can easily communicate with their physician, which is actually I would say probably the biggest barrier, especially with this. With our electronic health record, they made an upgrade about a year ago that made looking in other systems' records very easy if the patient's consented, especially since everybody here in the Twin Cities metro area uses the same type of EHR software. That's knocked down some of those barriers, but you still have that secure email system that we can access providers outside of our system or our affiliates, and that's a huge barrier.
And we try to maintain our exclusions and exemptions, because we still get ourselves in a fair number of cases that are very much in need of our services, but sort of just unique one-offs. This, I think, and so to come back to the whole telehealth piece, and to call back your attention to our map, is for our clinics are not able to do telehealth for many things because we're not in a telehealth okay area, meaning we're not recognized as underserved enough or rural enough in our clinic area so that people have been, there's no reason for them to adopt telemedicine. See, the way our compliance team and legal departments interpreted CMS's directions about TCM is that telehealth is an exclusion to those rules. So we can use telehealth to provide TCM services even in a metro area. Where this is relevant is when we first came out, we participate in the penalty of readmission, where if we do the work and the person readmits on day 29, we're not getting reimbursed for any of our time. We don't submit a bill to CMS or to Medicare. So we don't use the telehealth to turn around and do an E&M code for my time. So for our super highest risk people, what we try to do is still do a face-to-face visit so that we can make sure we capture because then I can convert my time into an E&M code, and then we're not just giving away, or, I'm not working for free or for penalties. So that's sort of the concepts. We'll talk more about our specifics now. This is, again, our customer with the CHF, and you can see John working here on one of our tough books, right at the patient side, right in their environment. And on our tough books, we have the camera enabled. And we bring with us, again, that a lot of technology. Which includes bedside labs. So TCM has allowed us to justify the purchase of point-of-care testing, and we use the Epoch for our device, But this way we can follow up with someone on day 3 and check their potassium or creatinine after making changes in their blood pressure medicine. So it opens that door to more things that we can do to help people at their house. And again, it's one of those, it highlights that the technology part of telehealth or telemedicine. And then this is the receiving end. This is me in my truck. This isn't the best camera angle to flatter my features, but it allows me to see the person face to face and connect real time. We work through a VPN, so it's all secure. But what it really allows us to do then is to be on wide areas, you know, across our service areas and still work together. And I can meet with John in a visit on one part of town and then meet with David, you know, 5 minutes later in a totally different part of town versus what we were dealing with before, which was me driving around and people having to wait and being very inefficient. It does highlight telemedicine, telehealth highlights for me, and I should have a naming contest for this, or maybe it exists already, but there is a inverse relationship between the importance of the information that someone is trying to relay to me and our audio quality. So, David, I keep asking, you know, we keep looking for the best solution in terms of microphones and equipment. And what's been very interesting to me is that our tough books, for whatever reason, if you're past a certain age, I haven't figured out exactly what it is, but past a certain age with hearing loss, you can't hear me speak through the computer. So in those scenarios, we'll mute the computer and we'll use our iPhones for the audio component while we continue to use VidYO as our video component. The computer's great for picking up chirping batteries on smoke detectors and then any radio traffic from the medic's radio.
If people are kind of trying to draw out what our infrastructure kind of looks like, and just so you guys have some specifics on how we have set things up here, we actually carry the same hardware as what the ambulance, all of our ambulance clinicians are carrying as well. So we use a Panasonic CF20, and then they all have internal Verizon cards that help them keep a 4G connection throughout. When we're working just a regular EHR, we can just log in through our hospital's Citrix portal. But when we're doing TCM, because it needs to be HIPAA compliant, we need that to live within the hospital's network. So we actually recently upgraded from an older VPN software to a newer VPN software recently. So we're using a VPN to tunnel into the hospital's network from the customer side. And then from that point, actually I should step back. Now we actually have to use our VPN all the time because we brought our ambulance clinicians also on, or our community paramedics are also using our North Memorial went to a new CAD system, so our community paramedics will actually create and end their own incidents in CAD from their laptops. Even though they may not have a GPS connection, they're still starting and stopping their incidents. So our dispatch system, or our dispatch center, knows where our community paramedics are when they've put themselves on scene, and then they're also getting 20-minute status checks over the radio since we're still maintain a radio connection. So continuing with infrastructure, we have our VPN going. Once we have our VPN open, then we are able to access our CAD system, our electronic health record, and then the software that we happen to use here is called VidYO. I think that's actually on our next slide. That is a HIPAA-compliant video platform. It's not without its challenges. We're looking at a system that's actually integrated within our electronic health record. We have a new chief medical information officer who's really excited about moving forward with an integrated platform as the budget allows. But right now, this VidYO software, which actually is kind of reutilizing a different piece of software, this is the system like we talked about how North Memorial Ambulance has 19 different service areas. Well, the ambulance actually initially bought VidWire so they could connect and video chat between our quality office in Brooklyn Center in the Twin Cities and our air care base up on the Iron Range up north of Duluth. And then they can also be on a video conference call with our ambulance quarters down in Waseca, down in the southern part of Minnesota. So it initially was a piece of software that the ambulance service was using for, business purposes, and now we're using it to allow this community paramedic and physician engagement.
The equipment piece, part of what has driven our decision making is this larger long-term goal of having the community paramedics really fully integrated to our 911 and interfacility system, and then also laying the foundation potentially for any of the ET3 work that we might take on if at some point where now it's not just the community paramedics connecting via telemedicine, but any of the medics connecting with however we morph in the future. So, I was thinking about calling this the Wingrove corollary or something, but it also works it might just be me, because this also happens with my spouse, where whatever they're trying to communicate to me, if it's super important, I can't hear them, and vice versa.
Ultimately, the workaround we're using when we can't get a good audio connection is we realize there's only a limited amount of bandwidth, and it's usually related to a mediocre Verizon connection. So we'll often, it actually happened with Pete and I on Friday. I was out in farm country, and we couldn't get a great audio connection and a video connection at the same time, so we just switched to running our audio connection over the speakerphone on my iPhone, which has a really decent speakerphone, and the sync up between those two is actually remarkable as far as how I see it. That's been it's not perfect, but it's a workaround that works.
So, and Epic is where we live and die by, so we keep trying to stay with them. So, and so this highlights some of what we've learned. So, you can see pre-televisits, my windshield time was high. I'm a half-time employee of community paramedics and EMS, and I was spending upwards of 18 hours driving a week, and that roughly translated to about 8 hours of patient visits, and that was about 4 or 5 people a week that I was being able to see face to face. And my visits, because I was going in and doing a visit, it was, hi, and let me get to know you. They were really fun hours that I was spending with people, and arguably well worth the time. But that included then me doing my set of vitals and me, figuring out that their dog food needs to get carried in from the garage. So doing all the stuff that I know that I've learned from the community paramedics, that's what we do. I was doing those visits, having a blast, but again, if it was the wrong administrator looking at things, a very inefficient model and not sustainable by any stretch. And then after we implemented the televisits, you can see the biggest thing here is my time with driving. It just dropped tremendously. I'm spending ideally about 6 hours a week on direct patient care, but that translates to about 12 visits a week now. And so the time that I'm spending with customers has dropped quite a bit. It's maintained the efficiency because the paramedic's still doing, the paramedic's still there for an hour and a half doing all the things that need to get done. But I'm just dropping in for about anywhere from 12 to 42 minutes to go over medication questions, prescriptive services, reinforcing the motivational interviewing that we're doing, and just answering questions, talking to people, and helping the paramedic problem solve. And so what it's also allowed us to do is really become partners again, because our community paramedics are going out solo. And I think, as a former EMS street provider, one of the things that I didn't like going out solo is I didn't have anyone to talk to in the car, or to go grab a bite to eat or have that partner with. And so I think I've really valued feeling again like I'm a partner of somebody's versus just a solo practitioner.
And on the paramedic side of things, I really appreciate, not that I don't like hanging out with Pete, but Pete's able to not be as kind of sucked into the situation as we may be. We're sitting in Pete's office right now. He's got a 24-inch monitor and a 19-inch monitor, and he's able to have a better, kind of more full view of what's going on with this patient from a chart standpoint. And I think it makes it easier for him to kind of unify things without kind of getting sucked into the fact that it's sweltering hot in this house, and that there's a peculiar odor that I haven't quite picked up on yet, or there's people moving in and out and talking on speakerphones and this, that, and the other thing. Pete's able to kind of bring in a kind of a different approach and do better chart research than really we can do, because those CF20s are great little laptops, but that's a small screen. And having more screen space, especially with something like Epic, it's nice to have that extra real estate.
Yeah. So this is, I think, this is a really talent. This is why I love, one of the reasons that when I meet with administration, why I love telemedicine is the efficiency that's gained.
And honestly, I thought, especially our, 65, 70, 80-year-old population would really kind of feel put out by the fact that this doctor is only willing to visit me by computer. But really the engagement, the adoption, the satisfaction that our customers are seeing with this telemedicine interaction is actually makes me, my initial instincts were completely wrong. Like when I first saw that study talking about how successful telepsych was, I was like, no, that's made up numbers. That can't actually be happening. But I honestly, I feel like the customers are actually able to make a meaningful connection with Dr. Tangy, and that's cool to see that happen, especially when people can still be very either ambivalent or afraid of technology.
Yeah, and I think one of the things that we're learning too is it helps having the community paramedic there to troubleshoot some of the technology issues allows that person to have a positive experience with telehealth, that we are hoping and have just made some very small inroads in transferring that to say, all right, if you sign up for my chart, you can televisit with your primary care doctor, and it should work in a similar fashion. So we don't have great success stories on that, just a couple of anecdotes. But I can think of two people who the community paramedic's been able to connect with, show them how to use their FaceTime so they can talk to their family members on the iPad that someone sent them. Or so kind of overcoming the technology issues has been good. And then from a readmission standpoint, we're in 2019 so far, 232 referrals. We've had 34 people readmit, and so our percentage is doing pretty good in terms of this. And it's another place where our hospital, as they look to help address readmissions, have reached out to our team, and we're one of the key stakeholders in our readmission work now that's going to start this fall. I think our group is essentially about 10 people. I would say we do have a spectrum of technology people. David and a good group of people being pretty savvy. We have one guy who, try as he might, is not the
average experience in our department for the paramedics is 34 years of time spent as a paramedic.
Yeah.
I'm at 16 years. I am very much the baby of the department. But you go anywhere from somebody who's been here for 45 and a half years and their technology skills, and you go to somebody else who's been here for, well, how long has Dale been here? For 37 years, and Dale is, I never have to hold Dale's hand. So it's a huge variety of skill level, but ultimately we've found a couple different things that work to make sure people can function in this really decently easy to use software.
Yeah. Yeah, and so the medics, I would say, are uniformly happy with the experience, but there was a lot of trepidation, especially on some of those folks who are less tech savvy, and so that we just needed to make sure we included that, or that it's not getting translated to the customer when they're when that person's getting frustrated.
Because I think generally for all of us clinicians who work in the field, this allowed us to get back in touch with a population, this Medicare population that we really, really enjoy working with. We had kind of shifted our focus for about a 6-month period away from most of our Medicare recipients and really trying to focus on Medicaid in mid to late 2017. I think a lot of people really missed that large Medicare population that they were able to work with. And I think people are really, really enjoying getting to work with that older population. They feel really akin to and whatnot. They like that.
And as a doc, it's allowed me to support and bring in my skill set of prescription writing ability, kind of broader medical knowledge outside of acute care medicine, and support the medics as they continue to build these really beautiful relationships with the people that we care for. So that's been fun to watch that in a more, again, before the televisits, I was having a lot of tangential contact with our customers, and then having some really powerful times when I get to see people in their homes. But now I've been able to multiply that kind of witnessing of that quite a bit. So that's been really good.
I think the other thing too is, and maybe this is actually, I don't see many more slides, but I think that we're not just using telemedicine just for TCM as well. Since we have that technology with us all the time, we're able to, I had a gentleman a couple weeks ago where, hasn't been to a doctor in touching a year, needs home care, needs a lot of different things, isn't really, getting to the clinic isn't really all that great of an option. We're able to, here and there use telemedicine to, have that face-to-face so Dr. Taney can legally write that home care order or that, prescription for this, that, or the other thing. It allows us to do those things that we weren't able to do before without, 43 different phone calls and waiting 3 days to hear back from the clinic or whatnot.
Yeah, just the efficiency it gives us and the ability to remain compliant and law-abiding, even if we're not able to generate a lot of revenue. It's been good. And then it's allowed us to expand even now where this is our, just to kind of end on a funny note, so this is our community, this is supposed to say community paramedic, but when we went to get it licensed by the state, they're like, you can't say paramedic if you don't have lights on it. So we call it our community health van. But it's, again, allowed us to identify that transportation is one of the big needs that we have, a kind of acute transportation need. So our van, we're able to provide that service to people as we're working towards a sustainable solution. And with that, we'd open it up to questions. We appreciate everyone listening in. And
Pete, Dave, thank you very much. That was a wonderful presentation. I think your take on the TCM approach to telehealth is one that may or may not have been tried by many people. How did you latch on to that as a solution?
I think it was, so we came to it as first saying we got to figure out how we can take care of this Medicare. We need to sustainably take care of the people on Medicare. And so we identified TCM and CCM as codes that would allow us to interact with people and get reimbursed for that elderly population. And so that's where we first started. And we've always, I think, had the idea about telemedicine or telehealth in our mind. And then once we were able to get that in place, it just allowed us to magnify our effect with TCM. But back to what David was just talking about is we're trying to solve the issue of geography. Telemedicine's always been at one of the solutions we thought would help us with that.
Question from the good Dr. Wilcox about wondering if Medicare Advantage plans are covering our service for Medicare as well. I totally forgot how to do pivot tables, so I haven't run through the spreadsheet yet. But now that we've got this, upward of 300 cases, that's one of our jobs in July, August, is trying to look more at our denials. And I have not. So the answer is I don't know the answer to that question right now. I think that some do, and some don't, and some don't some weeks, and some don't other weeks, is what I've been seeing so far. So what we're trying to do right now is put everything together and see what the pattern is.
Thank you. There was a question about is it possible to get access to this recording? Absolutely. And the same website that you registered on, which is cpif.communityparamedic.org, there is an archive button. Within a couple of days, you'll be able to go on and find that program archived there.
And there's a follow-up question from the Wilcox family, whether we're going to be able to share the information once it's completed, and I don't see any reason why we would be hiding our information for anybody. I don't think we've been in the habit of hiding really anything from anybody else in the world of community paramedics. I think, obviously we all know we're stronger together, and the things that are working really well for us, may work really well for you. So I don't see any reason why we wouldn't be sharing that.
Yeah.
Great. We were asked if we would send the website URL out to everybody on the call. I would just point out that you couldn't be on the call if you didn't go to that website in the first place to register, but we will send that out as soon as the information is up and posted, or this program is up and archived on that website. We'll send out the specific URL for this session to everybody who was on the call. I'm going to unmute the line so people can ask questions without necessarily typing them in the chat box. If you'll bear with me for just a second.
The conference has been unmuted.
Okay, so I invite anybody who is out there on the line to just speak up with a question that you might have or a comment. Such a quiet group today. If you are trying to speak, you are muting yourself. Okay. Sounds like we have no questions in the audience. No further questions from the audience. Dave, Pete, do you guys have anything that you'd like to add before we call it a day?
No.
Okay. Well, listen, I want to thank Dr. Peter Tange and Dave Johnson from North Memorial for their program today on telehealth and community paramedic. Again, this program will be placed on the archive within a couple days. We'll send everybody out the URL for that archive. Our next session will be on August 19th. One presentation during that session will involve a resource that just went up on the internet today from the National Rural Health Resource Center, which is a self-assessment tool for rural ambulance services, engaging how far along the volume to value continuum they have gotten. It also has a variety of resources based on that self-assessment to help services move along that continuum. So that will be at least one of the sessions in August, on August 19th at 3 p.m. Eastern Time. I would like to thank everybody for attending on behalf of the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research in EMS. Thank you, and have a good month.